So it is lecture 2 of our MRCP premium lecture series. Okay, we have started endocrinology. Today we will discuss the growth hormone. Okay, so what is growth hormone? It is a hormone that is released from anterior pituitary cells that are the specific type of cell that are somatotroph cell. We have discussed in our previous lecture, the first lecture, that there are different type of cells for in anterior pituitary that release different type of cells. Okay, so it is from the somatotroph cells. It acts on multiple organ systems and it is very important for the growth and the development. And it is responsible for the different changes like changes protein, lipids, and carbohydrates. So we'll study in the next picture what are the different actions of growth hormone in our body. This table is very important, this picture. So you can see in this picture, first of all, what are the factors that increases growth hormone? Okay. We will study what are the factors that increases growth hormone. First of all is sleep. Next is stress. Stress means hypoglycemia. Stress is different type of stress. Like stress is due to illness. Stress is due to hypoglycemia, which is a body stress, and also puberty and exercise. These are the triggering factor that can increase growth hormone, releasing hormone from the hypothalamus. Okay, so growth hormone, releasing hormone is released under influence of these factors. So growth hormone, releasing hormone will act on anterior pituitary, and anterior pituitary will release growth hormone. Okay, so this growth hormone then acts on the different type of the cells. So first of all, it will act on the liver and it is producing the very important, that is insulin like growth factor 1. This insulin like growth factor 1 is produced by the liver. Okay. That is very important because the growth hormone do all the function, most of the function by this insulin like growth factor 1. This insulin like growth factor acts first of all on the bone, and it will cause the what effects? It will causes increase amino acids uptake. It increases bone synthesis. It increases DNA and RNA synthesis. It causes increased deposition of the glycosaminoglycan and chondroitin sulfates. It increases the collagen deposition and it increases the cell size and the number when it acts on the bone. Okay. Now it acts on the muscles also. So insulin, like growth factor, when it acts on the muscles, okay, on the muscles. So what will be happening? It increases the protein and amino acid uptake. And the four most important is the adipose tissue. Adipose tissue. What is happening? What is the function of growth hormone on adipose tissue? Adipose tissue, it decreases glucose uptake. So that is very important concept here. So if this is decreasing the glucose uptake and increasing the lipolysis, so that's why the decrease in glucose uptake. So growth hormone is leading to insulin resistance. Insulin resistance sometimes it increases. Why? Because the uptake of glucose is decreased in peripheral tissue. So there will be increased insulin. Why? Because glucose is not going into the peripheral cells. The peripheral cells is adipose tissue. So there will be increased more and more insulin due to growth hormone. So growth hormone causes the insulin resistance, and insulin resistance will causes more release of the insulin. This is very important concept. Why? Because insulin like growth factor decreases glucose uptake in the adipose tissue. Okay. Next, we will discuss what are the factors that inhibits or decreases growth hormone. Okay. And these factors are the aging and obesity and hyperglycemia. But aging, old age, obesity, and hyperglycemia, they inhibit this growth hormone releasing. They inhibit this growth hormone releasing hormone, and then there will be a decreased release of this growth hormone. So this is very important concept. Okay. Next, what important question that comes in MRCP exam question? The next important question. Okay, it is important. What is the signaling pathway? Which of the following is the signaling pathway that's okay? The growth hormone acts. That signaling pathway is non-receptor tyrosine kinase. Okay, non-receptor tyrosine kinase. It is also called JAK-STAT pathway. Actually, there is a term we use usually, tyrosine receptor kinase pathway or receptor tyrosine. This is usually happen in the insulin. Okay, but growth hormone is non-receptor tyrosine kinase pathway. It is very important. This is also called JAK-STAT pathway. What is the mechanism of this? It acts on transmembrane receptor. Growth hormone acts on transmembrane receptor. They bind to the receptor and it causes receptor dimerization. Okay, and it's directly acts on the tissues, and sometimes it's released the insulin-like growth factors. Okay, so it can act directly and it can act via the insulin-like growth factor. Okay, we will study in the next picture what is this JAK-STAT pathway. What is our JAK-STAT pathway? This is a beautiful picture you can see here. Hepatic growth hormone that is released, and that growth hormone is acting on the important, very important. These are the receptors. Okay, these are called growth hormone receptors. These are hepatic growth hormone receptors. When the growth hormone this is attaching, so there is a JAK that is associated that is in the present in the cytoplasm. Okay, so when receptor is attaching, what will happen? This JAK will be attached to these receptor on the cytosolic side. And what will happen? There is a phosphorylation of this. Remember, there will be phosphorylation. Next step is the receptor phosphorylation. So when there is growth hormone attaching on these receptors, this is a step one. Next, what will happen? JAK from the cytosol will attach on the receptor. This is step two. And step three is the phosphorylation. What will be the phosphate group will be attached with this receptor. This is receptor. Next, fourth concept is that is a stat which is present in the cytosol will come and the phosphorylation of stat will occur. The fourth step is phosphorylation of the stat. And the fifth concept is dimerization, very important concept. Okay, these two stat will make a dimer. Okay, it is dimer. And this dimer is very important. So if this dimer is present in the cytosol, now it will enter into the nucleus, very important. Next is it will enter into the nucleus. You can see this is crossing the nucleus. This is nucleus. Okay? So when it crosses the nucleus, it will act on the gene. So it will causes the transcription factor activation. Transcription factor. Which factor? Insulin growth factor 1 will be produced. So when there is a transcription of a specific factor, so there is production of insulin growth factor 1. That is our product. That acts on the different, like bone, on the liver, on the muscle. That is very important concept here. Okay. So I repeat here, the hepatic growth hormone receptor. Okay, first it's attach on this receptor. Second, the JAK which is present in cytoplasm. Okay, there will be attachment of this JAK in this growth hormone receptor. And third concept is phosphorylation happen, phosphorylation of this blue which is receptor. And the fourth concept is the stat will come, stat will attach with this receptor and it will also be phosphorylated. Fifth concept is dimerization. Sixth is it will enter into the nucleus, and it is the sixth concept. The seventh is it will attach on the nucleus, DNA, RNA, so they will be causing the transcription factor activation, and the last eighth step is production of insulin like growth factor 1. Okay, so next, what are the conditions that are associated with growth hormone disorder? If there is a growth hormone excess, that is causing the acne. If there is a growth hormone less, that leads to the short stature. Okay, so what are the important concepts that are most likely asked in MRCP questions? What are the most important concepts? MRCP important questions. Okay. Growth hormone, along with the cortisol and adrenaline, they are called counter-regulatory hormones, and they tells the body to increase availability of glucose. Counter-regulatory means so it's actually counters the effect of insulin. So that's why they are called stress response hormones. Cortisol, adrenaline, and growth hormone, they are called counter-regulatory hormones. Very important concept here. And the next is, what are the most common side effects of growth hormone therapy? That is also asked, what is commonest side effect of recombinant hormone therapy? This is a question. Okay, that is fluid retention. Remember this, sometimes asked in the question, the answer is fluid retention. This is important question. Okay, what is fluid retention is the most common adverse effect of recombinant human growth hormone therapy. Also, sometimes it is associated with other like idiopathic intracranial hypertension, IHH. Also, there are other adverse effects like hypertension, atrial fibrillation, and pericarditis. We will study more detail in our next slide. Okay. The next concept is insulin-like growth factor. Insulin-like growth factor 1. Okay. Insulin-like growth factor 1 is increased, and sometimes it can be decreased in our body. So what are the causes that causes? What are the diseases that increases this insulin-like growth factor? That is acromegaly when there is excess hormone and pregnancy. Okay, next concept is, what are the causes that causes the reduction of this insulin-like growth factor? Decrease insulin-like growth factor 1. Okay, it will happen in the growth hormone deficiency, adult growth hormone deficiency, liver cirrhosis, because they are produced in the liver. reduce in the liver. So when there is a liver problem, there will be reduced synthesis. Okay. So what are the other causes that leads to the decrease insulin-like growth factor? The other causes are chronic kidney disease. They decrease insulin growth factor 1. They diabetes mellitus and starvation. Okay. So next our topic is hypopituitarism. Hypopituitarism. Okay. What is hypopituitarism? Hypopituitarism is decreased release of the hormone that are released from pituitary gland. Okay. So decreased release of pituitary hormone. This is hypopituitarism. What are the different causes or etiologies of hypopituitarism? We will divide one by one. First, we will study what are the pituitary causes of hypopituitarism. Then we will study what are hypothalamic causes of hypopituitarism. Then last, we will see the symptoms. First, we will study what are pituitary causes of the hypopituitarism. We studied in our first lecture that there is pituitary adenoma, okay, which is most common pituitary tuber. Sometimes it presented with a non-functioning pituitary adenoma. Okay? Pituitary adenoma can present with secretory and non-secretory. So sometimes it presents with a non-secretory pituitary adenoma. So when it presents with non-secretory, it can cause hypopituitarism. And there will be a metastatic mass. That also the cause of hypopituitarism. Next is hemochromatosis, infiltration of some compounds. Infiltration of iron is seen in hemochromatosis patients. That also leads to hypopituitarism sign. And there is infiltration of lymphocytes. Infiltration of lymphocytes into the pituitary that leads to the lymphocytic hypophysitis. Okay, the third concept is pituitary apoplexy. Pituitary apoplexy. It is actually a hemorrhage in pituitary gland. We will study more detail in next lecture. It is actually a hemorrhage in pituitary gland. And next is infarction. It is called Sheehan syndrome. It is happening in the post-pregnancy. Post-pregnancy or during the labor. Okay, we will study in the next lecture. So it is pregnant lady who come with a hypopituitarism immediately after delivery. It most likely is the Sheehan syndrome due to infarction of the pituitary gland. Okay, so these are causes of hypopituitarism in the pituitary. So there is a problem in pituitary. But now we will study if there is a problem in hypothalamus, because hypothalamus is controlling anterior pituitary. First of all is the mass lesion in the hypothalamus leads to hypopituitarism. Next is radiation therapy. And the third most important is the sarcoidosis. Sarcoidosis causes hypothalamic problems. Okay. So remember, the sarcoidosis is very important concept. It acts on hypothalamus. It causes decreased hormone from hypothalamus. And there is a trauma history. If there is a trauma happen, that also prevents the release from hypothalamus. Very important next concept here is tuberculous meningitis. This infections, this is very important. This is also decrease the hypothalamic hormone. Okay, hypothalamic hormone. This is also the cause of the hypopituitarism. Okay. Next, we will study what are the different clinical symptoms. What are different clinical symptoms that are seen? These clinical symptoms depending upon which hormone is deficient. If there is ACTH deficiency, we know that ACTH is very important to control the adrenal gland. Okay, adrenal gland is releasing cortisol, mineralocorticoid under the influence of ACTH. When ACTH is less, there will be secondary adrenal insufficiency. Okay, primary adrenal is problem when there is a primary gland problem. Okay, when other than the gland, if there is a decreased level of these hormones, this is secondary adrenal insufficiency. So ACTH deficiency causes secondary adrenal insufficiency. There are no mineralocorticoid, no cortisol. There are leading to postural hypotension, tachycardia, fatigue, weight loss, hypoglycemia, and eosinophilic. We will study in more detail in our next lectures. Okay, next is hypothyroidism, central hypothyroidism. We know that the TSH, thyroid stimulating hormone, that is less. Okay, so that is less. That leads to the hypothyroidism, like fatigue, cold intolerance, constipation, skin changes, bradycardia, decrease or slow dependent reflexes. Next are decreased gonadotropins. Okay, gonadotropins are also decrease FSH and decrease LH. They leads to amenorrhea and infertility in the woman, and infertility and loss of libido in the men. Okay, so we have discussed what are the different causes of hypopituitarism and what are the different hormones that are deficient and what are the symptoms of this deficiency. Okay, next is question. A 14-year-old girl who has brought to the annual checkup. He says the patient has always been a picky eater and he eats 3 meals a day. She used to stay up late talking to friends and go on bed after dinner. Blood pressure is 110/70 is fine, and pulse is fine, it is 62. On breast examination, there is a tenor stage 1. Tenor stage 1. Genital examination shows pubic hair consistent with tenor stage 4. The remainder of the examination is unremarkable. The patient's growth chart shows the height less than second percentile and declined growth velocity. So there is a 14-year age, and next concept is very important is that tenor stage 1, and there is third important concept is the height less than second percentile, and the fourth very important is decline growth velocity. What is the diagnosis? Okay. So our diagnosis in this patient will be which of the following diagnosis? The bone age is less than chronological age. That is a very important differentiating point. The fifth very important concept is the bone age is less than chronological age, which is the cause of this patient presentation. Okay. So in this case, our answer is growth hormone deficiency. Our answer is growth hormone deficiency. How? First, we will study this is actually a classic case of short stature due to growth hormone deficiency. Okay. This is a short stature due to growth hormone deficiency. Now we will study evaluation of a short stature in a children. Okay, how we can diagnose, how we can have a differential classification of a short stature in a patient. First of all, what is a short stature? Short stature is any children that is presenting on the growth chart that is height is less than second percentile. That is short stature. So in this scenario, we have seen that there is a height less than second percentile. This is short stature. Next, we have diminution. We will check that. Is there any dysmorphic feature? I will point out one by one question we will ask from the patient. That is very important. Step by step. First question we will ask, is there any dysmorphic feature? Okay, first of all, this will be the first question. Is there any dysmorphic feature? If there is yes, dysmorphic feature are present, so this is genetic disorder. Genetic disorders most likely have dysmorphic feature that present with short stature. Most common is the Turner syndrome. Turner syndrome. Next is the Down syndrome. Okay. And then is the skeletal dysplasia. These are the three most important genetic disorders that present with short stature and dysmorphic feature. Okay. Our next question, if there is no dysmorphic feature, that there is the no dysmorphic feature, so what will happen? Then we will check if there is impairment of growth velocity or not. Our second question is check the growth velocity. Growth velocity. This is our second question. The growth velocity is normal. Okay, growth velocity is normal. So we will go with this direction. Okay, this normal growth velocity. So growth velocity is normal. So what will be your third question? And if the growth velocity is normal, so what will be your question? Your question will be, is there any decreased bone age or not? Is there any decreased bone age or not? Very important. Here the question will be, is there any delayed puberty and decreased bone age? If there is yes, the decreased puberty and decreased bone age, our answer will be constitutional growth delay. But if there is a normal puberty, normal bone age, there is normal puberty and normal bone age and normal growth velocity, so what will be our answer? This is familial short stature. So here, make it so simple. The patient came to you. Okay, it is less than, height is less than second percentile. Height is less than second percentile. Your question was, is there any dysmorphic feature? No. Okay, there was no dysmorphic feature, and then we asked, what is the growth velocity? Is it normal or not? Growth velocity was normal. Then you ask the question, what is the bone age? It is decreased or not? The bone age is normal. This is normal, and this is also normal. So your answer will be familial short stature. Okay, what is familial short stature in this patient? There is a problem there. The problem is that the parents will also be the short. The history will be familial history. Okay, one of the parent will also be short. Very important concept. In familial idiopathic or short stature, one parent will also be short. This is a very important concept. Normal bone growth, normal age, normal growth velocity, and only the short stature. That is familial. But now we will go with another concept. Okay. First, we will ask the less than second percentile growth velocity is the normal. But very important concept here is that there is decreased puberty and decreased bone age. What is constitutional? This is constitutional growth delay. This constitutional growth delay is that when a specific period of time, like you can say 6 months to the 3 year, 6 months to the 3 years, this is a period when there is decreased bone age, and that's why we can say this is constitutional growth delay. But is there any problem in this patient when the patient will be in adult phase? No. You can reassure the parents that this is a smaller period of time. This is a temporarily growth delay. For a certain period of time, this child will be normal, and of course, the child will gain his adult height. Child will gain his adult height. And in this patient, in this patient, the parents are not short. Okay, there is no family history. Very important. So we have discussed in this short stature what are the normal growth velocity. So now we will go with our other side in which there is impaired growth velocity. Okay. Now we will go in which there is the impaired growth velocity. Okay. This is impairment of growth velocity. Now we will check short stature and impaired growth velocity. Then we will ask again bone age. Our question will be bone age. Is it is increase, decrease, or normal? There are three chances. Either it is bone age is decreased, bone age is normal, and bone age is increased. Okay, there are three scenarios. First, we will discuss where there is delayed bone age. Okay, delayed bone age. In this scenario, delayed bone age, there will be endocrine disorders. What are these endocrine disorders? These may be hypothyroidism. These may be growth hormone disorder. This is our scenario. Okay, our scenario is this one. Okay, it is, I have circled in the red line. Okay, our patient presented with short stature. Our patient presented with decreased growth velocity. Our patient presented with delayed bone age, and it was due to endocrine problem, that was growth hormone deficiency. Is that clear? So in the other differentials, if we can see, if there is a normal bone age, there will be a systemic diseases, and systemic diseases are celiac disease. Systemic disease is the celiac plus IBD, inflammatory bowel disease. This is normal bone age, but growth velocity is impaired, and normal bone age, this will be a celiac disease. Next very important point is, if there is increased bone age, then what will be our differentials? Okay, if there is the increased advanced bone age, this is the concept precocious puberty is the answer. Okay, so this is the evaluation of short stature. We have discussed one by one. I can summarize this in just 2 minutes. First of all, a patient came, you have to evaluate if the height is less than second percentile. If the height is less than second percentile, which you will see on growth chart, you have diagnosed the patient is a short stature. Okay, and next you will ask the question, is there any dysmorphic feature? Yes, if yes, then you can suspect Turner syndrome, Down syndrome, and skeletal dysplasia. You can suspect any of these three. If there is no dysmorphic feature, your next question will be, is the growth velocity normal or impaired? The answer is growth velocity is normal. You will go from this side. If normal, then you will ask, what is the bone age? It is decreased or normal? So if bone age is normal, then there will be a familial short stature, and you will see that one of the parents will also be short. Then if there is normal growth velocity, but there is a delayed bone age, there will be constitutional growth delay. There will be a specific period where the bone age will be decreased, but in adult height will be maintained after the age of 10 or 9. Okay, next we will go to this side. Okay, next, if there is no dysmorphic feature and there is impaired growth velocity, then we will have a three situation. If there is a decreased bone age, normal bone age, and increased bone age. If there is a delayed bone age, there will be the differentials of malnutrition and endocrine disorder. In endocrine disorder, we have the two most important, that is hypothyroidism and growth hormone deficiency. If there is a normal bone age, there will be a systemic diseases, systemic celiac diseases, inflammatory bowel disease. If there is advanced age, there will be very important, that is precocious puberty. Okay, so this was the overview of the short stature and diagnosis of the short stature. So our here the concept was growth hormone deficiency. Well, now we will discuss the growth hormone deficiency a little bit more. Okay, what is the cause of growth hormone deficiency? What is the cause of growth hormone? The most common cause of growth hormone deficiency is the pituitary tumors. Okay, and their treatment. What are these? Like surgery and cranial radiation. Okay, so these are the most common cause of the hypopituitarism, or which leads to growth hormone deficiency. And maybe other cause of hypopituitarism we have just discussed in the above slide. Okay, but growth hormone deficiency will be the most common in the pituitary tumors, like with non-functioning pituitary adenoma we have discussed, and their treatments like in surgery and cranial radiations. What are the features? What are the features that are in infancy? The growth hormone presented with hypoglycemia and micropenis. So penis will be small. That is presenting in the infant. In early childhood, the growth failure is very important finding of growth hormone deficiency. Okay. In early childhood, the growth failure is primary manifestation. And very important concepts that is sometimes asked in exams. This is important concept here, important question. That is premature fusion of epiphyseal portion of the bone. So there is, if there is growth hormone deficiency, what will be happening? Premature fusion of epiphyseal plate. Okay, this causes the decreased height. Okay, in adults, what are the symptoms in adults when there is growth hormone deficiency? In adults, there is increased fat mass. We have studied that the growth hormone in normal patient causes lipolysis. It decreases the fat mass, but when there is a deficiency, it will increase the fat mass. And we studied there is an increased protein synthesis in muscle. So when there is growth hormone deficiency, what will be happening? It will be decreasing lean body mass. Okay, we have studied it increases the bone growth. So it will be decreasing when there is a deficiency of growth hormone, there will be decreased bone mineral density, lead to osteopenia and osteoporosis. There will be decreased energy level in our body. So the quality of life will be decreased. Okay, there will be more sweating, dry skin. There will be greater mortality and increased risk of cardiovascular disease. And in some patients, LDL is also raised in growth hormone deficiency in adults. Okay, this is our the features in different. So we divided the feature in infancy. What are the features in infant? That is hypoglycemia and micropenis. Then we studied the features in early childhood. Early childhood features will be the growth failure, premature fusion of the epiphyseal plates that lead to decreased height. Then we studied the feature in adults. These are decreased fat mass, decreased lean body mass, decreased bone density, decreased energy, decreased quality of life, sweating, greater mortality, cardiovascular risk, and dyslipidemia. Now we will study the diagnosis. How we can diagnose growth hormone deficiency. We can, of course, check the very important, that is insulin-like growth factor. We will check insulin-like growth factor in the body. And very interesting, it is normal. Even there is growth hormone deficiency, in 50% of the cases, it is normal. So what are the tests then we can diagnose growth hormone? There are different dynamic tests of growth hormone secretion. This is a very important topic. What are the different tests that are used for the growth hormone secretion? These are dynamic tests of growth hormone. First of all, we have studied in our first lecture, that is what is insulin tolerance test. In our first lecture, we have studied in detail what is insulin stress test, insulin tolerance test, and insulin induced hypoglycemia test. These all are same thing. Insulin tolerance test, insulin stress test, insulin induced hypoglycemia test. These all are same. Okay, we give the insulin, IV insulin, and it produces artificially the hypoglycemia environment. And hypoglycemia is a stress, so it causes more release of anterior pituitary hormone, that is growth hormone. So if there is a normal increase in the growth hormone after giving the insulin, if normal increase in growth hormone, so it's mean it's okay. Like greater than 18, this is normal response, greater than 20. But if we give the insulin and still growth hormone is less than 9 microunit per liter, this is threshold. If less than 9, so we have a diagnosis of growth hormone deficiency. Okay, very important concept. This is less than 9, that is growth hormone deficiency. Okay, next concept is what is false positive test. Okay, if we give the insulin and growth hormone response comes less than 9, okay, in another condition, that is false positive. This test will be false positive in obesity. Why? Because you know that in obesity there is insulin resistance. So when we give insulin, the growth hormone response to insulin will be false positive in the obesity. Next important concept, what are the contraindications? We also studied in our first lecture. It is a quick revision. Contraindication of insulin tolerance test, that are seizures, okay, ischemic heart disease, abnormal ECGs, and elderly patients. Because in an elder patient, there are more risk of hypoglycemia, who cannot do the test. So if these are the contraindication, if then in these patients, what are the alternatives? Yes, alternatives are tests. These alternative tests are the arginine growth hormone stimulation test. Next is the glucagon growth hormone releasing hormone stimulation test. And the next is the third one, very important, we will study in the next slide, which is Messi-Morellin test. Okay, one by one we will study this. If there is contraindication of insulin stress test, what will be our next test? Next test is arginine growth hormone stimulation test. Arginine growth hormone stimulation test. What is this? Okay, why it is arginine given in this growth hormone? You know that growth hormone releasing hormone, this is released from hypothalamus. Okay, normally it is released from hypothalamus. Only growth hormone releasing hormone. But this arginine growth hormone releasing hormone is it is artificially we have produced in the lab. Okay, this is the lab hormone we have produced in the lab. So we give so that we can increase the production of the growth hormone. Why? Because it acts on anterior pituitary as like the same GHRH that is released from hypothalamus. Okay, so what will be the action? What will be the dose? A bolus of 1 mcg per kg body weight is given intravenously to the patient at the time 0, and immediately we give the infusion of arginine hydrochloride. Very important concept. First, we give 1 mcg per kg body weight IV bolus of growth hormone releasing hormone. Okay, this growth hormone releasing hormone, when we give the IV, immediately after that, we add a compound that is arginine hydrochloride. Arginine hydrochloride. What is the dose of this? It is given into 0.5 gram per kg. Okay, and maximum we can give only 30 gram. Okay, so we will check before the giving of these injection, like 30 minutes before, and we will check the growth hormone at 0 level. We will check after 30 minutes. We will check after 1 hour. We will check after 1.5 hours, and then we will check after 2 hours. We will check the response. Okay, if there is increased growth hormone, then it will be the normal. It's fine. But if the hormone release is cutoff value is less than 4.1, this cutoff value less than 4.1 is diagnosis of the growth hormone deficiency. Okay. A very interesting thing to mention here is that a growth hormone releasing hormone is not available in the United States. Okay, it's not available in the United States. Okay, so going to our next, what is glucagon? Going to our next, what is glucagon stimulation test? A glucagon test is most likely recommended by some of the countries like the USA, where growth hormone is not. Okay, the countries where growth hormone is not available, in that countries, glucagon stimulation test is used. What is this? We give 1 milligram glucagon intramuscularly, and then we measure growth hormone after 30 minutes to the 4 hours. If the growth hormone is less than 3 nanogram per ml, then we, in a normal patients, then we consider its growth hormone deficiency. Okay, but this cutoff value is changed if the patient has obesity. In obese patient, the cutoff value is the less than 1 nanogram per ml. Okay, and normally when we give glucagon, there must be increased growth hormone. But in this patient, there will be no increase in growth hormone. There will be less than 3 nanogram per ml. So it's mean it is the patient has growth hormone deficiency. So it was glucagon stimulation test. Now we will discuss what is important next is the what is mesomorelin stimulation test. Mesomorelin is a compound actually. You can this it is an agonist of ghrelin receptor. Okay, it is agonist of ghrelin receptor. Okay, what is ghrelin? What is ghrelin? Ghrelin is hunger hormone. Remember, it is hunger hormone. Okay, we know that when there is a hunger, like a fasting, the ghrelin is released and it gives signal to the hypothalamus. Okay, so on the reverse of this ghrelin, the opposite of ghrelin is leptin, and we have in a more like a obesity, or we have a more well-fed state, the leptin is released. So ghrelin is the hunger hormone. Okay, when this is increased when we are in a fasting state. So this mesomorelin is the agonist of this ghrelin. So when we give this, okay, first of all, before going to discuss this, why we should give it mesomorelin? This test is only recommended on those patients where insulin growth factor are normal. Okay, in those patients where the insulin growth factor, because the first diagnostic test we discuss is the checking insulin growth factor 1. If insulin growth factor 1 is normal and still you are suspicious of the growth hormone deficiency, then you will do this test, massive ghrelin test. Okay, this is ghrelin receptor agonist, and when we administer, okay, what is the dose? The dose of this will be 0.5 milligram per kg, administered in the morning when there is a fasting condition. And we check the growth hormone at zero level after 30 minutes, 45 minutes, 60 minutes, and 90 minutes. Okay. So, in a subnormal increase in the growth hormone concentration in the patients who has organic pituitary disease, confirm the diagnosis of growth hormone deficiency, who has the serum insulin growth factor equivocal. It means in those patients who have the same level or normal level of insulin like growth factor and still has a suspicious of the growth hormone deficiency, then there will be a subnormal increase, not normal. This is very important point here. Subnormal. Okay. So it's mean there will be not a normal increase in growth hormone when there is a subnormal below the normal increase in growth hormone when we give this mesomorelin. So it's confirmed that the growth hormone deficiency is present. Still, the insulin growth factor will be same level, normal level, but there will be growth hormone deficiency present if mesomorelin test is positive. Is that clear? Now, so we have discussed the different tests. What were these tests we have discussed? We will check insulin growth factor 1. We will check the level of growth hormone. Then we will check, we will do the test of insulin stress test. Okay, when there is contraindication of insulin stress test, we will go for the arginine growth hormone releasing hormone test. And if the arginine growth hormone releasing hormone is not present like in USA, then we will go for glucagon stimulation test. Okay, then if there is a normal insulin like growth factor 1 and we have a great suspicious of this growth hormone deficiency, then we have discussed, we will do the test which is massive ghrelin stimulation test. And the next we will discuss the what is the treatment. What is the treatment of growth hormone deficiency? We know that the growth hormone deficiency treatment is recombinant growth hormone therapy, which we give the subcutaneously injections. Okay, subcutaneous injection of recombinant human growth hormone. Interesting thing is here, what is criteria? Okay, what is criteria for growth hormone treatment? These three, 1, 2, and 3 must be met. These three must be met before going to start growth hormone therapy. What are these three important criteria? One is that the severe growth hormone deficiency must be present before starting the recombinant human growth hormone. What is severe deficiency? The growth hormone response less than 9 microunit per liter. Okay, 9 microunit per liter or 3 nanogram per milliliter during or after insulin tolerance test. That is a one criteria that must be met before starting the growth hormone therapy. The next important concept is derangement of quality of life, impairment of quality of life. What is quality of life? Actually, there is an assessment criteria to check what are the different symptoms we see in growth hormone deficiency. Okay, this is called quality of life assessment of growth hormone deficiency in adults. QOL, A assessment, growth, G growth, H hormone, T is deficiency, A is the adults. So it is assessment of growth hormone deficiency in adults. This is a questionnaire which is more than like 23, 4, 5. These are questions. Okay, daily life questions. We will check, we will ask from the patients, and we will check that if the score is greater than 11, so it is also the criteria to give the growth hormone deficiency. You can Google it and you can find all the questionnaire. Okay. Third is the treatment for other pituitary hormone deficiency. If one person is also taking the hormone, pituitary hormone due to other diseases, due to other deficiencies, then you must also add this. Okay, you must also add the growth hormone. Next, what are adverse effects of growth hormone? What are adverse effects of growth? These are sodium and water retention that leads to fluid retention. Very important question that it is a first question of MRCP. Okay, this is an important question. That is sodium and water retention leading to now this sodium and water retention leads to what? Weight gain, carpal tunnel syndrome. Okay, and growth hormone also lead to insulinemia. We studied why? Because it causes insulin resistance. Glucose is not going into adipose tissue because it inhibits glucose uptake by adipose tissue. What will happen? More glucose will retain in the body, and more glucose will stimulate more insulin, so it will cause hyperinsulinemia. Okay. And we have studied they have effect on chondrocytes and osteoblast cells. They increase the protein growth. So what will happen? It leads to increased growth of cartilage, leads to arthralgias and muscles pain, that is myalgia. Also intracranial hypertension. And this IHH, this is only resolved when we stop the treatment. Okay. What are the contraindication? It is the third time we are repeating this. What are contraindication to the growth hormone replacement? We are not going to give this growth hormone in the active malignancy, benign intracranial hypertension, and very important, proliferative retinopathy in diabetes mellitus patients. Proliferative, because you know that the growth hormone causes the increased cell size and cell growth. Okay, so what will happen? It will causes the exacerbation of the retinopathy. So that's why we cannot give the growth hormone in the proliferative or pre-proliferative retinopathy in diabetes. Okay, next we will study the question. A question in MRCP. MRCP question. Which treatment is most appropriate for the patient with preserved pituitary function and deficiencies in growth hormone and adrenocorticotropic? Okay, which treatment is most appropriate when there is preserved pituitary function, deficiencies in growth hormone, and adrenocorticotropic? In this patient, we will give the cortisol replacement therapy. Okay, in this patients, we will give the cortisol replacement therapy. Why? What is the reason? Why not growth hormone? Because this cortisol is very important to having the effects of growth hormone. Okay. So when we give the cortisol, okay, the effects of growth hormone will be resumed. So sometime the growth hormone and other hormones have not having the effects due to decrease release of the cortisol. So when we give the cortisol, growth hormone will also be having the same effects. So sometimes growth hormone deficiency is caused by the hypoadrenalism. So when we use the cortisol and the growth hormone therapies, okay, combined, then it can restore the growth hormone secretion. That is very important. Okay. So now today we have discussed the most important concepts about the growth hormone, and we have discussed the short stature and different types of the short stature and how to differentiate between them. Okay, and we also discussed today what is hypopituitarism and what are the different causes of hypopituitarism and what are the symptoms. Okay, so it was our lecture 2 of premium MRCP series at SIMS Academy.